Good afternoon, everyone. We'll give it just one more minute. All right, we'll just get started here. Hello, everyone. Good afternoon, and welcome to our industry showcase on September 28th. My name is Ashley Caesar, and I'm the Programs and Event Specialist here at Digital Health Canada. So today's webinar is presented by Enovacom, Transforming Data into Insights. And joining us today is Mr. Alain Larochelle. He's the Country Manager for Enovacom. We have Dr. Asad Siddiqui, the pediatric anesthesiologist at the Hospital for Sick Children and assistant professor at the University of Toronto. We have Robert Greer, our computer scientist. He's a software engineer and a systems architect in the Department of Critical Care Medicine at the Hospital for Sick Children, Toronto. And we also have Sébastien Delecole, technical manager for Canada as a biomedical engineer, who specializes in clinical and medical administrative interoperabilities, my apologies, solutions. Okay, so we will have time for Q&A at the end of today's presentation. Please type your questions in the chat box at any point. And thank you all for being here today, and I will pass it over to you, Alain.
Thank you, Ashley, for the introduction. Well, there's a reason why you decided to attend this seminar, and I suspect some of you may be looking for a solution to relieve some of your clinical staff from tasks that simply adds little value to their work, such as transcribing vital signs into the hospital EMR. Some of you yet may be having challenges in getting some of those scarce resources, such as in IT, to be assigned to prioritize some of your biomedical projects. Some of you, I know, are puzzled to understand how does Enovacom Solutions fits into the enterprise architecture with already so many existing solutions. But I've also heard that some are thinking ahead, and they want to see how this vast amount of data generated by your medical devices can actually be tapped into to bring insight in order to help those clinicians inform their decision making. And well, also, I hope that none of you are here to test their capacity to sustain yet another Zoom meeting. But if you are, thank you, I guess. But thank you all for attending this webinar. Ashley kindly introduced our esteemed panelists. But before we dig into, I dive into some questions for Dr. Asad Siddiqui and Mr. Bobby Greer, I just want to give you a bit of a prelude of the webinar. Just like Ashley said, we're going to start with Q&A. Well, Q&A, I guess we're going to start with a panelist with Asad and Bobby, where I'm going to ask them some questions. Most of the webinar will be spent interacting with Asad and Bobby. At the end of the webinar, we will have a Q&A where you, the audience, will be able to send your questions directly to SickKids and to me, as a matter of fact, if you want me to answer some questions as well. Before that Q&A at the end of the webinar, Sébastien Delecole will be running through a demo. Rest assured, this is not going to be a crash course on our solution. This is meant to show you just a quick preview of how easy it is to use Enovacom Patient Connect, our biomedical interoperability solution, and how it integrates easily and seamlessly into workflows such as nurses, clinical engineers, and IT staff. So we want to make sure that you understand that our solutions really help hospital staff focus on the front end of the project as opposed to the back end. So as Ashley said, I would advise you to note your questions. You can pose them in the chat box, or you can wait towards the end of the webinar just before the Q&A to submit your questions. I also ask for your indulgence and your understanding. If you don't get to go through all of the questions, given the number of people that's in the webinar, we may have to defer afterwards, and we'll be happy to address some of those questions after the webinar. So as we start, I think Hospital for Sick Children, SickKids, deserves no introduction. They're a tier 1 world-renowned organization, teaching hospital. So I'm going to dive right away into the questions for Asad and Bobby. So let me start with you, Asad. Well, obviously we have to keep in mind that we're asking questions with the perspective of data capture and management, as a broad subject. What are some of the objectives of SickKids and of yourself that you want to fill around data in the context of anesthesia?
Thanks, Alain. I think one of the really important things to recognize is that in the OR, we have a vast amount of data being captured on all of our patients pretty much continuously throughout surgery. So our goal right now is to find a solution for actual data storage of this large amount of physiological data and signals within the OR. So goal number 1 is definitely to actually find a way of capturing and storing this data in an accurate way. And we want to capture this data in an all-encompassing way as well. So right now we look at data in a lower resolution where we capture it maybe every 5 minutes. When we look at something like blood pressure, that's what we're recording. But we're looking for a way to look at it in a higher frequency and having that raw higher frequency physiology available to help us gain insights into different patient physiological states and how they correspond to the different things that happen in the operating room with the patient.
Great, thank you. And how about you, Bobby? From your perspective, what are some of the objectives that you want to fill around data in the context of anesthesia?
So in the context of anesthesia, I guess I'd take it one step further. Asad's obviously gave a lot on the anesthesia part itself. I come from critical care. I've built, myself and my team have built Atrium DB, which is our high frequency waveform data management system. I guess one of the big goals and opportunities we have here with working with anesthesia is to integrate that data into our existing data from the ICU, which is part of our broader goal to create this unified physiological data record for our patients across all the units where they would receive continuous monitoring. And I guess I would touch on beyond the clinical side of things, this also presents a great research opportunity. There's a ton of data embedded within this data, a ton of information that we can, that is yet to be unlocked to provide insight for our patients. And, by collecting and storing all of this data, we can tap into it and try to unlock some of that potential.
Yeah, and I think building on what Bobby said, I think it's really important to recognize that there's a lot of continuity within the hospital. So like the operating room in critical care, particularly, like we have a lot of continuity within physiological states between those two places. So as Bobby mentioned, kind of finding that connection is really important for us.
Well, that's interesting. You mentioned data collection, but there's got to be a number of challenges as well as opportunities faced by all of your departments in data collection, integration, and management from a clinical, research, and IT biomedical perspective. Can you talk to us a little bit about some of those challenges and opportunities?
Yeah, so I think one of the big challenges and a very important challenge that we have to recognize is the accuracy and the reliability of the data that we actually capture from the operating room. So for example, how do we approach things like artifacts? Do we look at them in an insightful way? Do we try to look at them in different ways? How do we identify things like artifacts? How do we annotate things that are happening in the operating room and correspond them to the physiological states of patients? So just a few examples would be when surgical incision occurs, when intubation occurs, when we're inducing anesthesia and having all these drugs go in, how do we correspond the annotation of these events with the actual physiological data that we have? Because I think the first step is really to store and capture data in an accurate way, because in order to actually gain insights, we have to have a degree of confidence in the information that we're using to gain those insights.
I guess I'd take that one step further and say, I mean, there's the technical challenge of collecting and storing the data, and that's often seen as a technical challenge, but there's a kind of a less technical side of it as well. When we first started collecting data in the ICU, getting bedside staff to routinely collect ventilators up so that we could collect data was a big challenge. And there's a lot of information in the presence or absence of signals. And if we don't reliably collect data from different devices, we can't exploit that. For example, talking about artifacts, there's also a huge amount of information in those. So it's important to know that we're capturing the right artifact, if you will, and not a side effect of collection.
Yeah, and I think having raw data, building on what Bobby just said, is important, because there's a lot of information within raw data, and it's more unbiased to have raw data, and ensuring accuracy and lack of bias when we're starting our platforms of storing these data is very important.
You mentioned something that really caught my ears, Bobby, when you said you can get a lot of information from the presence of the data or from the absence of data. Can you talk on that a little bit? How can you draw information from not having data?
So one thing, if we think of patient acuity, for example, if we look at a patient's kind of physiological record as they stay in an ICU, and for example, as they start to get better, you would expect a patient that comes back from Assad, from the OR to the ICU, you would expect them to be very intensely monitored, have central lines, arterial lines, and things like that. As they start to get better, as we hope they do, things like that start to be removed. And we don't always easily know that they have been removed from things like the electronic health record. But as the data starts to fall away, and you start collecting fewer and fewer signals, you can infer, or we strongly suspect you can infer the patient acuity based on that. That said, the opposite is also true. If a patient's in the ICU not heavily monitored and they start becoming more and more monitored, you can infer from that as well that the patient is becoming more and more acutely ill.
And Assad, you mentioned about having value in collecting the raw data. I mean, today, all hospitals collect some level of data. It goes into the hospital EMR. Why wouldn't you source the insight through the information that is already stored in your premier data storage capacity? Why would you not go and get the data from the hospital EMR, as an example?
Well, right now, what we're trying to do is get the higher frequency physiological data that the ICU already has established for many years. So the waveform data like ECG, saturation waveform, as a few examples, arterial line waveforms. So our goal is to integrate the higher frequency physiological data capture technology to integrate with what we've already been doing in the ICU for many years. So when I say raw data, what I mean is exactly what Bobby's saying, which is, when we see artifacts, like, we want to know that there was an artifact there. We don't want to have something that's already been changed on our behalf when we go back to look at it for whatever purpose that might be, whether it's research or clinical. We want to know when these access points and artifacts occurred. And that's what I mean when I say raw data, which is we want to know what it is, when it happened, how it happened. And we want to be able to recreate those situations as if we were in that situation again.
Right. I guess this is a good segue. Oh, sorry, Bobby, go ahead.
No, I was just going to add, I mean, typical data solutions right now, to get this raw data, you would typically use like a central monitoring system, or you dip into your EHR. EHR typically isn't at high resolution. And when you look at central monitoring, that's great, but I guess the philosophy we have here is that we want to also go way back in time. So if you think of a patient that you had 2 years ago, and you want to go and dip in and look at their waveform data and look at exactly, like, for example, if they had a cardiac arrest and you want to look exactly at what the ECG did leading up to it. That's typically not something you can do today. So we want to obviously provide that ability.
Well,
Yeah,
it's
or
a
even
good
if you want to know, oh, sorry, Alain, I was going to say, or even if you want to know something as simple as how many times the art line was accessed in the hour leading up, or the central line was accessed in the hour leading up, you'll figure that out from artifacts and those kind of things that would tell information.
So you need vast amount of data, and it's a good segue into my next question. So how do you envision artificial intelligence and machine learning algorithms to contribute to some of your current practices? And at what stage are we at, or what stage is SickKids at, or even the industry as a generally speaking, with respect to AI, and how we can ensure that the approach of using those algorithms is actually viable? Good question, huh?
Yeah, it is a good question. I'll speak from my side, and I'm not a clinician, so don't hold me accountable in that respect. I think we're starting to see a lot of I know a lot of work come out in the area of physiological data with AI and ML type approaches. My group here, Lawson Labs, including which Assad is a part of, has been doing a lot of work in that area, and I see it as a really unique methodology for integrating the vast amount of data that we are collecting and transforming it into something that is actionable and usable at the bedside. I don't see it as replacing a clinician ever, frankly. I see it as augmenting and helping people like Dr. Siddiqui, who needs to look and manage at tons of patients post-operatively, as well as potentially a patient that's in the OR right now. So being able to help them integrate all of these different signals that he gets into actionable information or insight, or help guide his thought process, is where I see it going. In terms of where we're at right now, I can speak to us here. We have multiple models that we run on live data feeds within the ICU that we're hoping to also get going through this project in anesthesia, that are running and providing insight at a silent trial level.
Mm-hmm. And I think I completely agree with Bobby in the context of it being in the future something along the lines of a clinical decision support tool that works in collaboration with different healthcare providers. I think, like most technological advancements historically, there's always opportunities that are made available by certain technological advancements. If you look at it from something simply like OR technology, like saturation probes or ECG monitoring, like when that was integrated, there was a question of how you would integrate that, how it would be used, what safety improvements would it actually implement. We're at a stage where now we're having technological advancements in other areas and similar questions are being answered. And it's exciting to think about what potential there might be. But clinical decision support tools is certainly something that comes to mind when we think of AI and machine learning from that perspective. In terms of viability, I think I've said this a few times now, but to just kind of hammer it home a little bit, I think the viability of it really comes down to the quality of the data that we're looking at when we're making things like algorithms. If you're making a training data set to develop an algorithm to predict something, the quality of that algorithm is only going to be as good as the data that was used to train that algorithm. So it's really important at the early stages to, again, like I said before, have confidence in your data, make sure it's reliable data, that it's unbiased data, so that when you move forward, the validity of it, when you apply it to other external situations, is reasonable validity.
So you're talking about biases in the data set. Do you have any initiatives where you actually participate with other teaching hospital or other hospital establishments? Because not the bigger the data set, the better the data, but the bigger the data set, potentially you can root out some of those biases. So what's the approach of SickKids with respect to, partnership or collaboration with other organizations in Canada or across the world to make sure that those sets are robust enough to remove any biases?
So it's an interesting challenge because this is still a fairly new area of work. Us here, I mean, we've developed Atrium DB, which is our kind of data management and deep learning kind of platform. We're in the process now of going live at 5 different hospitals specifically to address this challenge, which is to test external validity of the work that we've done. Currently, our models are only tested here. That doesn't mean that they generalize, obviously, and we want to build models that work broadly. So in the goal of going live at these other institutions is to not just facilitate them building up their own data set, but to also foster collaboration and validation of models, both their models on our data and our models on their data.
Yeah, and I think a huge first step is actually just recognizing that it's a potential issue. Because I think if you recognize that it's a potential issue, then you can start these mitigation strategies early on at the ground level when you're developing the ways that you're actually going to capture and store the data. And like Bobby said, then you can establish ways that you're going to guide your collaborations to expand on the potential validity testing.
So what are I know you've talked about it broadly, but what are the specific benefits that you see to the healthcare providers, to the patients as well, in using those artificial intelligence and machine learning algorithms?
So I guess I could speak to my utopian view of the future. Really is to provide kind of useful insights, timely useful insights and kind of aggregations of data, to use a technical term, to people like Dr. Siddiqui here, so that he can focus more time on the care that he's given. So from a patient perspective, what that would look like is a clinician that has more time to interact and do the human side of care, and needs to spend less time sitting behind a computer doing this analysis.
Yeah, definitely. And if you look, like, again, I'm very interested in the history of vital signs and technology, because I think history often gives insight into how things develop in the future. If you look at something like historically, people used to feel pulses manually to see what the state of health might be. Then the development of technology that allowed for blood pressure management came along, and people were actually able to get numbers. And then when they started getting numbers, they were able to figure out what normal ranges were, what abnormal ranges were, and what interventions you need to do to manage those. So now when we're getting more technological advancement, we're at the stage where we may develop new insights into human vital signs and how to approach that vitality, and then to determine what might be abnormal that we may not have had the opportunity in the past, because similarly to clinicians in the past, we may have not had the technology allowed us to see certain insights.
Right, so it's difficult to see what some of the benefits may be before you actually deploy the technology. And Bobby had, at some point we were talking and you came up with the Wright brothers analogy, right? Where...
Yeah. Yeah, it's I guess the context of the analogy is, well, we're kind of comparing it to, like, if you were to ask the Wright brothers, what the world of commercial, transport looks like, right? Of commercial airfare. It's not really a fair thing to say. We're really at, in this whole field, at like the original Wright brothers flight. Like, we're just starting to take off. We don't, we have a great idea of where we think it may go, but we don't know yet really where it's gonna go.
Right.
But I, for one, am excited for the future.
Great. So a question with respect to that, not with respect to that, but a good segue again, is specifically in the project with Enovacom, what are you trying to achieve and address, and why exactly?
So from a technical perspective, we found Enovacom through our need to integrate the devices in the OR. Unfortunately, there are two unfortunate things happened. One, as is not uncommon at all in hospitals, our device stack in the anesthesia world is different from other places in the hospital. So we had the unique challenge. And as a result of that, our existing integration partner, who has since been acquired by Baxter and mothballed, this is also unfortunately common, that we used in the CCU, doesn't support Draeger devices. And so we started kind of surveying the world of providers around that would be able to provide us the high frequency data that we wanted. And what we found is that there are some challenges with other players around how data is manipulated and changed to make it useful for the typical use cases that exist today. And I should say there's a difference between data science use cases where you need highly accurate data and typical use cases of waveform data today, which is in like visualization interfaces. So through our experience in a similar relationship with the previous company we worked with, we're hoping to work with Enovacom to ensure that the integration that we do with Draeger is giving us fantastic data from a quality perspective, and more than anything, isn't manipulating the data in any way. We want as raw of data as possible to ensure that the models that we can build on it and the tools more broadly that we build on the data are as accurate as possible.
Yeah, I completely agree with what Bobby said. Like to me, from a clinical side and a research side, it's about the integration of this high resolution data to actually have it and capture it and integrate that with what we're already doing in the ICU. And as Bobby mentioned, there's different devices and challenges that come with having those different devices and how we capture that technology. So that's what we're trying to achieve. Accurate, reliable data capture and storage in an environment where we're very data rich, which is the operating room and the ICU.
Right, and how do you envision the key learnings around these large data sets to be used in the future? I know it ties back a little bit about what we said, but specifically for your project.
Yeah, so I think there's different ways, right? So one that certainly comes to mind that we don't talk about as much is from a quality improvement perspective. I can see a lot of value in having this data stored and retrievable and visualizable. So you can go back and look at certain events that you need to review retrospectively and have a source of truth within the data if you have that raw data stored and captured. And you can use that for visualization to assess how you can improve or what might have happened in terms of events in the operating room. And then the other one that we've talked about kind of a little bit more at length is regarding clinical decision support tools and the development of that. So there is some literature, for example, that's looked at arterial waveform analyses intraoperatively for predicting hypotension during intraoperative cases. So concepts like that give insight into if we have this raw data, well, it can be used from a research and clinical decision support tool perspective, and to achieve that using the higher resolution physiological data.
Great, but with respect to that, can you talk a little bit about the sovereignty of the data? Because you're talking about, accessing the data, trying to use them to get some insight into the data. I know we've talked about this a little bit, but in the context of what you just said, how important is it for you to have some kind of an independence to access the data, and how do you operationalize that inside SickKids?
Yeah, certainly. I think it's very important to have independent access to data from our perspective. Historically, and Bobby can speak to this more, we've had direct access to our data from the ICU in the past, and we want to achieve the same thing with our intraoperative data as well. So whenever we need to use it for something like quality improvement, research, clinical decision-making, that we have immediate availability to access what we need.
Yeah, I guess taking that one step further, I think it's very important to us that we have ultimate control to export the data and to manage it. I think I feel strongly about that, because one thing we need to keep in mind is this actually isn't our data. This paid data belongs to patients, and we need to govern it as such. But to truly enable use cases or make it easy for clinicians to access data, it's ideal for it to not require some third party involved. So we don't want to have to contact a vendor to, with a request and have them pull data for it and curate and give it to us. The more we can access it ourselves, the better. And I mean, my perspective too, I like having things like open APIs built on top of the data so that anybody can come and build tools. So we can foster the best tools, not just the one that, a single company has provided. We can allow anybody to build tools on the data and come up with new and unique ways to visualize the data or analyze the data.
Great. Well, thank you, Asad and Bobby, for very insightful answers to some of those questions. I'd like to now to give some, to turn it over to Sébastien. So Sebastien will walk us through a brief demo before the Q&A. Remember, I mentioned that our biomedical interoperability solution is 100% software-based. And I had a discussion with a client last week when they asked us, what's 100% software-based? What do you need by that? So I have these things, and I think everybody knows that, right? It's like Office. And some of you, if you're old enough, you know what that is, right? It's a CD. And today, nobody would ever think about upgrading their Microsoft by putting I don't even think people have CD players in their laptop anyway. So obviously we're 100% software based because this is the new reality. A client showed us their ICU unit, and they showed us a picture of their ICU unit, and they said, realistically, Alain, do you think I can add one more piece of hardware in that configuration? Where would I? Of course, respirators, pumps, we need the hardware there, but if we can go without hardware for some of those back-end solutions, then they would rather deploy that. I am not saying that there is no other architecture that's viable out there. That is not what I'm saying. But in terms of modern times, what we ask is our clients to challenge a little bit the status quo of how the interoperability is actually deployed in hospital. So I fully understand that for some components you absolutely need hardware. That is not my point here. So today we think that one of the configuration that's usable, acceptable, viable is without hardware. And that also reduces the pressure on the IT staff, because as you will see from Sebastien, the solution that we deployed is going to demo Enovacom Patient Connect can be deployed, configured by non-IT staff. So IT staff typically are part of our solution, but they are not core and center to the deployment of our solution. So we have actual clinical engineer that can do some of the configuration. We get involved some of the clinical staff as well, not for the configuration, for the use, but all to the benefit of the patient. So now I'd like to pass it over to Sebastien, who will give us a snapshot of Enovacom Patient Connect. Sebastien, the floor is yours.
Thank you, Alain. Thanks for the introduction. Well, first of all, let's put in the situation that you are a healthcare professional. In few words, imagine that you are an anesthesiologist and you are in the OR. You have to do an operation, and for that operation, the anesthesiologist plays a critical role. In fact, the anesthesiologist has to check for the patient's physiological signs at every moment. So you as an anesthesiologist, you play a very important role. And the point is that during the operation, you have to check at any moment the vital signs, the physiological signs, but you, as an expert in those physiological signs, you have to report them either in a template document or directly in your specialized OR application or hospital EMR. The problem is that imagine you have to report the vital signs in your application, software application for the OR. You have to turn your back to write on your computer the vital signs, and you don't have the patient in sight. And that's a great risk, I would say, because if there's a change in your physiological signs, that means that the patient is about to wake up. You have to react immediately to adapt, for instance, the infusion pump, to adapt anything to make the patient fall asleep once again, to ensure that there is no risk. That's one of the risk. And you know, in the OR, you have a lot of devices, such as in critical care, for instance, but you're currently an anesthesiologist in the OR. So you have to check the monitor, the respirators, to check the infusion pumps and other devices that require your intervention. So in those cases, you would like not to have to take vital sign and put them in the software for the OR. That's why Patient Connect was created. That's just an example. You have the same issue in the critical care when clinicians have to take vital signs every 10 minutes, for instance, or every hour. We would like with Patient Connect to avoid that operation, that manual operation, that is a non-variable task. So let me share my screen and show you Patient Connect in few minutes. So Patient Connect already logged and as a clinician, and you can see here, imagine yourself an anesthesiologist. You plug the patients on the devices, and once the patient is plugged to the devices, you prepare the device collection. The point is that Patient Connect will automatically take vital signs and push the vital signs in the hospital EMR or your specialized application. The first step is to start the device collection. How it works is very simple. As a healthcare professional, you're totally able to do that. And in few clicks, you will do the operation. So you're in this screen, the interface, you access by many ways regarding the project. And once you're in that interface, you just have to select your patient. You have the list of devices that can be associated to this patient, and you just have to click on the one or the devices you want to associate. Once you selected all of them, you click on save. And once you click on save, you just check that you have the right patient with the right devices that you want to associate, and you click on yes. That's all that you have to do as a healthcare professional. And for all the operation in the operating room, you do not have to report any vital signs. So you win a lot of time. You have all your time to check for the patient and the patient safety during the operation. So that's what we want with Patient Connect. It's not only to feed the beast, I mean, the EMR, the hospital EMR, but it's also to improve, to get a better treatment for the patient by only caring of the patient's health and to keep an eye on the patient in the operating room at every moment. For instance, in the critical care unit, you do not have to take vital signs for each patient at every moment, every 10 minutes, for instance. And in case of emergency, you do not have to leave the patient's room without having taken vital signs. Everything is done automatically. Another important point with Patient Connect is the frequency of the retrieving and the collection of vital signs. You know, regarding the care unit in which you want to collect the vital signs, you have different frequency to take the vital signs. For instance, in the OR, you want to take vital signs every minute, every 2 minutes, to have a close history of the patient vital signs. But in the classical hospital units, you just have to take vital sign every hour. That's another important point in Patient Connect, and that's where healthcare professionals have to participate in the project. They are the end users, so they are likely to tell us what to do with the vital signs. And for the frequency, during the project, now let me show you the administrator interface right here. You have to prepare the frequency once the healthcare professional told you what they want, a specific entry called data management rules. The data management rules enable healthcare professional to give their idea of the frequency of the data, and the IT administrator or even a biomedical administrator can configure it in Patient Connect very easily. As you can see here, you have a list of rules, and we have sampling duration rule type. I currently highlight it, and you can create as many rows as you want. You can create raw data sampling of 1 minute, 5 minutes, 1 hour, 10 seconds. Really depends on what you need. Once you created your sampling duration, that's very simple. You just have to say, I want 10 minutes. And you can also go further, saying that I want a specific vital sign to be out of the sampling duration. We will not go further in that demo. Once you created your data management, you just have to associate the sampling duration to the device. So you click on the left side on the entry devices, and you have the list of all devices that you've created in Patient Connect. Those devices can be created by IT administrator, biomedical administrator, and may even be created by clinical staff, because it's very simple to create one device. Just let me give you an example. I will take one device randomly. And what you have to do is just to say the brand of the device model, and then the library of the device. So the library is just how we communicate with the device, and how we transform the data to be understandable by any software after that. It's automatically filled, and then you have many information, very easily understandable, to put the device in your situation, in your case, I mean, in your care unit, how you will use the device. And finally, you have the specific rule that you want to apply to this device, and you can apply the sampling duration. Once the sampling duration is selected, and you save the configuration, for the next association of that device in the care unit that you want, automatically the sampling duration of the frequency will be applied to that device. Meaning that if you are in the OR and you started the device as a healthcare professional right here, you do not have to do anything else. And every 5 minutes, for our example, the last data received by Patient Connect will be sent to your application, the hospital EMR, or any specialized OR software. So now we have seen how easily the healthcare professional can associate a device. What's the frequency behind that to get the vital signs? Now let's see the last part, the receiving applications. So I will come back to the administrator side. And on the left side of the interface, you have receiving application entry. You click on it, and you can see the list here of the receiving application that have been already created for the example. And you can create as many receiving application as you want for one device or one care unit. Meaning that for one care unit, you can have 1, 2, 10 or more receiving applications. For instance, let's take the data lake receiving application. So that's very simple to create a receiving application. You just have to say the name of that one, the facility that contains the application, and finally the point of care in which you want to collect the vital signs for that application. That's the main point. And finally, you have 3 kinds of data. I talked about vital signs for the example, but you note that you have 3 kinds of data: the measurement reception, the vital signs as already presented, the alert reception, or more precisely the alarms for an alarm management system. For instance, if you want the clinician staff to receive notification from devices, if there is an alarm directly in their mobile phone, you can send alerts to biomedical staff. And finally, the waveform reception, the waveform, for instance, where you can push them in your data lake, then exploit them by crossing information between patients. You can use them for, as we talked sooner, machine learning, artificial intelligence. And thanks to the three kind of measurements, any receiving application can have data from Patient Connect. And just to conclude in a few minutes, Patient Connect produces information in a standardized format, HL7, and can, thanks to the interoperability engine of Patient Connect, transforming it to any other format that you want. For instance, a FHIR standard, so JSON format, to any other standard, or a non-standardized format such as CSV. You can push PDF files with vital signs inside that. It's all as you want. So to wrap it up, Patient Connect helps avoiding non-valuable tasks as reporting vital signs. Patient Connect wants to improve the quality of care by avoiding transcription errors of vital signs. And we had some projects where in the critical care unit, for instance, the healthcare professional took maybe 5-6 vital signs, and thanks to Patient Connect, they decided to take 10-15 vital signs that are provided by the devices to improve the quality of care and to make more precise analysis with any vital sign that are produced by those devices. So that's all for me. Alain, I'll let you the lead once again, and thank you for your attention.
Thank you, Sébastien. I've seen that a number of questions are coming in. There's one question with respect to integration and how do you integrate to an already existing number of platforms. I had that question just sent to me particularly, but I'll deal with that after with Bobby and Assad. So let me take some of those questions. I'm just gonna read them out. And Assad and Bobby, maybe you can try to address them, if you will. So one of the questions is, how can one best deal with the lack of explainability of some of these AI models when hoping to integrate them into the clinical workflow?
So it's a great question, and it's one that I've definitely gotten before. I think, yeah, you're alluding to something that is true. I mean, deep learning models or AI models that are implemented are honestly a black box, and it's not like the data scientists of the world, understand what's in it and nobody else does. Honestly, they don't understand really what's going on either. So, I mean, how do we address it? I think there's a couple ways. One, first of all, there's an entire body of research that's going on now that's actually looking at, once you have a model built, reverse engineering what the model's doing to try to tell you what it's doing, to try to turn the black box that is the model into a gray box. So if we think of an ECG rhythm detection, for example, say you had a model that's detecting your heart rhythm based on an ECG waveform. There's an approach called attention mapping, where you run data through the model and it would show the particular areas of the ECG waveform that the model's tuned into. There's been initial research in that area, and unsurprisingly, it tunes into the same areas that clinicians that are classifying those rhythms themselves look at. I think the other thing to address it is to provide a level of transparency around the confidence of a model. So a model will always give you an output. It just may or may not be an accurate output. And some of the tools that exist today and models that have made it into clinical care, I found haven't always put a lot of transparency on that. So what that means to the clinician downstream is, well, the model doesn't reflect at all what I'm seeing in front of me. So by default, I'm not going to trust it. I feel strongly that if you attach a level of confidence, which is not, very challenging to do from a data science perspective, and say, the model thinks that, in 5 minutes, this patient's going to have a cardiac arrest, but it's only 20% sure that that's going to happen. Well, then you'll probably look at the output of that model a little differently. And then I think, philosophically, the highest level way of dealing with it is is to look at a model like another piece of information for a clinician. There's always information that you're going to disregard and information that you're going to use when you come up with care. If the model doesn't make sense, then don't use it, and look at that. And but selfishly feed that information back to the people that are building those models, because that helps us make these things better.
Right, and I saw Asad react to that last point of Bobby.
Yeah, I think that's key of just recognizing that it's another tool, right? Like that can supplement our information. Like explainable AI is a huge area of research for people in AI kind of research areas from a computer science perspective. But from our end, if we're applying these as clinical decision support tools, at the time, that's what they are. They're support tools, right? We use them with a grain of salt. We use them how we see they fit the clinical situation. And there's probably a lot of technology that we use that we don't know exactly how it works, but we use the information with a grain of salt. So I keep harping on blood pressure, but the non-invasive blood pressure cuff or your arterial blood pressure monitor, a lot of people may not know the inner workings of it and exactly how it derives the numbers it derives, but we often trust those numbers, except when it doesn't make clinical sense. And then we look a little bit deeper as to why the numbers are coming up the way they are. And I think it's the same thing with AI until we start getting more insights into it.
Right, well, thank you for that insight. There's another question about the privacy implication. They say of this initiative, but I think maybe the way we portray that, this is not an initiative. This is, operations as normal as it can be. But can you talk about the privacy implication of using data for some of those models, or broadly speaking?
So, with respect to what we've done here, I mean, we manage privacy in the same way that you would any other clinical data system. Our physiological waveform database that we have here is classed as a clinical system. We manage it and are responsible to it as such. So we have to meet all the same security, privacy guidelines set out that you would hold your Epics or your Cerners to as like gold standard clinical systems. In terms of, I guess, from the research side of things, our data access is governed by our research ethics board here. We receive REB approval. The vast majority of research that we do, except for specific cases, the data is all de-identified and anonymized, and we use the standards that are set out as Mimic as an open source database that's real patient data that's de-identified. We manage our data, or de-identify and anonymize it in the very same way. And I know anecdotally with that data set that's broadly publicly accessible, there hasn't been a single case of patient identity being teased out from the actual data set. So that's our approach here.
Asad, anything to add to that?
Yeah, I just think it's important to have that collaborative approach with privacy. Like our research ethics board has been great when we're doing research in terms of how to identify rare events and keeping it anonymized at the same time kind of thing. So certainly it's a growing area, but Bobby covered most of it there. Yeah.
Thank you. Another question is about patient and medical device association is critical and the workflow must be seamless. How do you ensure that the correct device is associated with the patient? And just before I open this up, just want to make sure that the participants understand that through Enovacom Patient Connect, we have a number of ways to do patient to device association, right? So there's, I think we have 6 use cases of that association. So we think we cover pretty much a whole spectrum. But if I go back to what you're doing at SickKids, Bobby and Asad, how do you ensure that the correct device is associated with the patient? Which is a good question.
Yeah. So we approach it in 2 separate ways. So in the case of anesthesia or in the ICU, a lot of bedside devices are permanent fixed assets. So our approach for data collection, we store all data based on the device that it originated from, not the patient that it originated from. Then we track ADT through the hospital, patient locations, and for all the fixed assets, if you know a patient's in bed A and you know that Draeger monitor, this Draeger monitor 6 is in bed A, then you can infer which patient's on which device. It gets more challenging, obviously, in devices that move. So we've integrated continuous EEG data, which is on devices that there's, I think, 6 of them in the ICU, and they move around. In that case, the neurotech inputs the patient's MRN, and we do some validation to make sure that MRN is correct and that that patient actually is having an EEG, and we link it that way. I know with infusion pumps coming, they'll be assigned by scanning a barcode. But a really interesting problem, and not one that definitely doesn't have a clear answer, but that association in terms of data is a lot more fluid, I think, than people think, which is why it's important to have a system that's flexible enough to allow that to change, and in a kind of a non-destructive way to the underlying data. So that's basically where the approach comes from, of decoupling the data from the patient itself.
And that's a great point, because obviously what you've seen from Sébastien is another way of doing it for example, for a patient that are being hospitalized for a long period, as an example. But we have many ways of doing patient device association. But a great way to answer the question, Bobby. Did you want to add anything, Asad, or can I go to the next question?
You can go to the next one. I mean, I can add, because there was a comment about high turnover cases in the operating room. So in the operating room, we use Epic for device integration currently, and we scan each patient's armband ID barcode per patient encounter in the OR. So that's how we integrate the correct patient with the device.
And we think that's key. In my dealings with hospital staff, clinical staff, sometimes there's a discussion with respect to being very productive and skipping some steps so that we can do that automatic patient device association. And in other places, the clinical staff says it is our responsibility to do that positive patient identification. So we try to cater to what the hospital workflows are, but certainly we don't think, just like Bobby said, we don't believe that there's a one size fits all. Especially even within a hospital, you can be in the OR, the ICU, CCU, or in the wards on top where the patient is being hospitalized, and you may have different ways of associating that patient to the device, and we need to respect that to a certain extent. Otherwise, it's just the IT folks, the software folks, imposing a way to the clinical staff. And from my little experience that I have over the past 2 decades, that is not a recipe for great adoption from the clinical staff. There's another point where it says in other countries, so it's somebody that outside of Canada, that's going to be my last question. You're going to have 30 seconds to answer it, and I'll let Asad manage that stress. They say, with the acceleration of digitalization of the process of vital sign collection and rapid association of devices with patients, they say, our solution meant to optimize the patient flow with real-time data visibility at the point of care so clinician can make quicker decisions? Is it more about reducing the level of interaction with medical device equipment by staff to reduce the risk of virus transmission? What drives some of those initiatives, or is it a melting pot of all of that?
I think it's all of the above that you've kind of mentioned. Certainly you need data visualization, you need data acquisition, and the COVID pandemic certainly applied new concepts as to the utility of having an automated process of capturing this information, which includes, not contaminating your workstation, for example. We have very particular protocols for how we keep clean and dirty stations during COVID patients. And part of that is certainly facilitated by automated capture of our charting system. So certainly I think it helps with that workflow, and then also from the other aspects that you mentioned as well, Alain.
Thank you. Well, I want to be respectful of people's time, and I want to give Ashley a 30-second to wrap up. Dr. Siddiqui, Mr. Greer, Asad, Bobby, thank you very much for your insightful answers. I hope that was of value to our many participants, which we're glad that you were able to come on board. If you have any follow-up questions, don't hesitate to contact any of the people around the panel or myself. Ashley, back to you for conclusion. Thank you.
Great. Thank you, everyone. Great conversation, great discussion. As Alain said, please feel free to reach out to any of us if you have any additional questions. I'll put my email address in the chat as well, and I could put you in contact with any of our panelists. Okay, so just a quick share here for tomorrow. Tomorrow's webinar, Wednesday. It's called Bright Squid: Secure Communications in Health Cities. Please go onto our website to register there. Our Atlantic Region Virtual Conference is coming up next week, Monday, on October 4th. And following next week, our webinar Wednesday is overview of AI implementation toolkit, and this is with Canada Health InfoWay. Our next industry showcase is AWS and CrowdStrike. And we have the convergence of healthcare and education with Ticket Health on October 20th. And then AWS is going to be our industry showcase for the month of October, and November 4th as well. So there's October 21st they present with CyberMDX and Eastern Health. And then we have the building branches gathering requirements through co-design with Nova Scotia Health to finish up the month of October. All right, everyone. Well, thank you very much for your time. I put my email address in the chat if you want to quickly jot it down. If you have any further questions for any of the panelists, please reach out to anyone and we'll be happy to assist. All right, thank you again, panelists. Thank you, attendees. Have a wonderful rest of day.
Thank you and be safe.
Thanks a lot.
Thank you, everyone.
Thanks all. Bye.